Good afternoon, everybody. I'd like to welcome you to this session. This is a session of rapid-fire abstracts. My name is Shom Goel. I'm a medical oncologist and lab scientist at the MacCallum Cancer Center and the University of Melbourne in Australia. It's my pleasure to be moderating this session. Just a few words about how the rapid-fire sessions will run. We're going to hear 7 abstracts in the next hour. Each speaker will describe their study to us in 5 minutes, and then we'll have 3 minutes for questions. Those questions can come from the microphones. I believe there was a QR code that was shown before. You can also use that to ask questions online. And what I'll do is, here it is now for you. And what I'll do is, as each speaker is announced, I'll ask them to come up, give their presentation, and then take a seat at the table and stay up here with us for the entirety of the session. Okay, so time is of the essence, so let's get started. Our first speaker is Dr. Jennifer Ligibel from the Dana-Farber Cancer Institute in Boston, and her presentation is entitled Effect of a Weight Loss Intervention on Metabolic and Inflammatory Biomarkers in Women with Obesity and Breast Cancer, Results from the Breast Cancer Weight Loss Trial, or BWEL trial, run by the Alliance. Dr. Ligibel, please.
Thank you so much. I'd like to thank the conference organizers for inviting us here today to share our results looking at the impact of the BWEL weight loss intervention on metabolic and inflammatory biomarkers. All right, we're going to do there we go. Why is this not? I get extra time for this. Oh, there we go. So obesity is associated with poor outcomes in early breast cancer. Individuals with obesity at the time of breast cancer diagnosis are at increased risk of cancer recurrence, cancer-related mortality, and all-cause mortality compared to leaner women. We don't fully understand the biologic basis for this connection between obesity and poor outcomes in early breast cancer, but observational studies and preclinical work suggest that obesity may impact breast cancer through adverse effects on interconnected metabolic and inflammatory pathways. And in fact, studies have shown that individuals with metabolic dysregulation, higher levels of inflammation, have poor outcomes in early breast cancer. The breast cancer weight loss trial is a phase 3 randomized trial that was designed to evaluate the impact of a diet and exercise-based 2-year weight loss intervention on invasive disease-free survival in 3,180 women with stage 2 and 3 HER2-negative breast cancer and a body mass index of at least 27 kilograms per meter squared. We are still awaiting the primary outcomes of this trial. But last year, we presented data demonstrating that women randomized to the weight loss intervention lost 5.7% of baseline body weight versus controls at 12 months. Today, we will present another key secondary outcome, looking at the impact of the weight loss intervention on metabolic and inflammatory biomarkers in these patients. All participants underwent collection of fasting blood at baseline 6 and 24 months. C-reactive protein, insulin, and leptin were assessed in a central laboratory. All specimens from an individual patient were analyzed in the same batch. 10% of samples were run in duplicate. Non-fasting samples were omitted from metabolic analyses, and two sample t-tests were used to compare mean change over time between the two groups. 2,867 individuals had available specimens for these biospecimen analyses. There were no significant differences in the patients who had specimens available versus those who did not. At baseline, average BMI was slightly higher than 34 kilograms per meter squared, so well into the obesity range. Almost 80% of participants had hormone receptor positive HER2-negative cancers, and the vast majority of patients were treated with chemotherapy, endocrine therapy, and radiation. Here you see the impact of the weight loss intervention on metabolic biomarkers, starting with leptin. Levels of fasting leptin were decreased by, I can't read this without glasses, 24.5% in intervention participants versus controls at 6 months and more than 15% at 24 months. Similarly, levels of fasting insulin decreased in intervention participants by slightly more than 20% at 6 months and almost 20% at 24 months. This population of patients had elevated insulin resistance at baseline with median scores of 4.3 in both groups. Insulin resistance decreased by more than 25% in intervention participants at 6 months and more than 16% at 24 months. There were also significant, although modest, differences in inflammation levels as measured by C-reactive protein at 6 and 24 months, with reductions in the intervention group versus controls. We were also interested in looking at the correlation between changes in biomarkers and weight loss, and we found a positive correlation with leptin and weight loss with a correlation coefficient of 0.57. There were weaker correlations between weight loss and change in other biomarkers. We were also interested in looking at the correlation between changes in waist circumference and changes in these biomarkers, since this is a better measure of abdominal adiposity. We found positive correlations with all biomarkers, but in general, these correlations were weaker than with weight loss. So in summary, the breast cancer weight loss intervention led to improvements in metabolic biomarkers, insulin resistance, and to a lesser degree, inflammatory biomarkers. These results demonstrate a physiologic effect of the degree of weight loss that was induced by the BWEL intervention, and future work will evaluate whether changes in biomarkers correlate with improvements in cancer outcomes. I'd like to conclude by thanking all of our steering committee, the many, many people who volunteered for the study, our funders, site investigators, and patients. Thank you.
Thank you, Dr. Ligibel. Do we have any questions?
I'm sorry.
Yes, at microphone 6, please.
Thank you for that very elegant, eloquent presentation, beautiful data. I wonder, bearing in mind the MA32 data, which was very similar, do you foresee in the future that weight loss, rather than taking a tablet, will be the best way forward?
That's an excellent question, and I think when you look at other studies with other endpoints that have compared the effect of metabolic treatments like metformin and weight loss, such as the diabetes prevention program, in fact, weight loss was much more effective in preventing diabetes than metformin was. We saw significantly more weight loss in our study than had been seen in metformin and MA32, but I think that that is really the central question, is whether we will see improvement in breast cancer outcomes in this study, which was not seen in MA32.
One more question, microphone 6 again.
Dr. Ligibel, thank you for that excellent presentation. Just to follow up on that question again, these are expensive studies, but women like them when they participate. Can you comment on some of the methods that you are implementing for sustainability aspect of the study? Thank you.
Absolutely, and I do think that taking a step back, while it is true that lifestyle interventions do have expense to them, that when we think about the amount of money that we spend on the pharmaceutical agents that we use to treat our patients, that if a study like this demonstrated benefit, this would have a huge, huge effect on outcomes for a fraction of the cost that we use for many of the drugs that we use to treat patients. But I think one of the things that we were excited about with these data was seeing the sustainability of these changes, especially in metabolic biomarkers at 24 months. It's a long period of time to be intervening in more than 1,500 individuals enrolled from across the country. We are continuing to follow weight change over time. We were very, very encouraged by seeing the durability of these changes in biomarkers out to the 24-month time point. Thank you.
Thank you, Dr. Ligibel. I'll now invite our next speaker to the stage, Dr. Luca Malorni from Prato, Italy, The title of his presentation is Palbociclib plus letrozole versus weekly paclitaxel, both in combination with trastuzumab and pertuzumab, as neoadjuvant treatment for patients with hormone receptor positive, HER2-positive early breast cancer.
Thank you. Good afternoon, everybody. On behalf of the co-investigators of the TOUCH trial, I would like to thank the organizing committee for choosing our study for a rapid-fire presentation today. These are my disclosures. So patients with ER-positive and HER2-positive early breast cancer have an unmet clinical need. And recently, preclinical and clinical data have shown that CDK4/6 inhibitors plus endocrine therapy and, of course, anti-HER2 therapy may have a role in chemotherapy de-escalation strategies in this setting due to their efficacies. However, biomarker strategies to allocate patients to such de-escalation strategies are lacking. So we have previously developed and characterized RBSIG, a gene expression signature of functional RB1 loss that is composed of 87 genes that are associated with E2F1 and 2 function. So high levels of RBSIG are associated with both resistance to CDK4/6 inhibitors in a luminal breast cancer model and also in patient samples. But at the same time, high levels of this signature are associated with sensitivity to chemotherapy in patients with ER-positive and HER2-positive breast cancer. Therefore, we hypothesized that RBSIG status might be a biomarker for selecting patients for de-escalation strategy of chemotherapy in favor of CDK4/6 inhibitor treatment. With this hypothesis, we designed TOUCH. This trial initially included an elderly population of patients aged 65 years or older, but was soon amended to include postmenopausal patients independent of age. Patients with ER-positive and HER2-positive breast cancer larger than 1 centimeter and with a clinical node status of 0 or 1 were eligible. 145 patients were randomized to receive either paclitaxel at a dose of 80 milligrams per square meter on day 1, 8, and 15 every 28 days for 4 cycles, or palbociclib for 4 cycles in combination with letrozole. In both arms, dual anti-HER2 blockade with trastuzumab and pertuzumab for 4 cycles every 3 weeks was given. So the total duration of treatment was 16 weeks in both arms, and then patients proceeded to surgery. The primary objective of the study was to explore the interaction between treatment activity and RBSIG status measured on pre-treatment biopsies by RNA sequencing. Pathological complete response in breast and axilla was the primary outcome measure of the study. The study assumptions were that the backbone of paclitaxel would achieve a better PCR rate in patients with RBSIG high status, while palbociclib plus letrozole would be more active in patients with RBSIG low status, as indicated in the table here. The study, importantly, was powered to detect a significant treatment by RBSIG interaction. So 145 patients constituted the treatment population, including patients who received at least 1 dose of trial medication, and the population accessible for the primary objective was 115 patients who had received at least 1 full dose of trial treatment and, of course, had the RBSIG status successfully determined by RNA sequencing. The study population was mainly composed of older postmenopausal women with a median age of 69 years, and 75% of the patients were clinically node negative. Treatment was well tolerated in both arms. Early discontinuation due to adverse events was reported in 16% of the patients in the paclitaxel arm and only 2.8% of the patients in the palbo plus letrozole arm. In the treatment population, pathological complete response rate was 32.9% in the paclitaxel arm and 33.3% in the palbo plus letrozole arm. In the accessible population, no significant interaction between RBSIG status and treatment arm was observed. Therefore, the study hypothesis was not supported by the data. So in conclusion, TOUCH is the first randomized neoadjuvant trial in an ER-positive, HER2-positive population to explore a de-escalated chemo-free backbone of palbociclib plus letrozole versus paclitaxel, both in combination with trastuzumab and pertuzumab. The primary hypothesis was not supported by the study data, but additional translational studies are ongoing to uncover potential new biomarkers. Interestingly, a PCR rate of about 30% was observed in both study arms, aligning well with prior studies in this setting. And of course, these results support further investigation of these strategies in dedicated clinical trials. On behalf of all the TOUCH team, I would like to sincerely thank all the patients and their families and the study staff who made this trial possible. I would also like to thank the study sponsors and those who funded the study. But finally, this presentation today is dedicated to the loving memory of Dr. Angelo Di Leo, whose vision, leadership, and knowledge were instrumental to make this trial possible. And thank you all for your attention.
Thank you, Dr. Malorni. We'll take questions now, starting again, microphone 6.
Hello, this is Ahmed El-Kanani from Baylor College of Medicine. Wonderful work, chemo-free regimen, and BET-CR appears numerically to be the same. Would there is any analysis that was done on the intrinsic subtyping and its relationship to achieving BET-CR in these ER-positive, HER2-positive patients?
Oh, thank you very much for this beautiful question. Yes, we did some PAM50 analysis on the RNA-seq dataset of the assessable population. I didn't have space to include that in the presentation. We do not see any interaction with PAM50 subtypes and treatment in this study. Interestingly, and in accordance with prior results from other studies, we see a high PCR rate in patients that have a non-luminal phenotype, which is mainly composed of patients with an HER2 enriched subtype. And this is, PCR rate is close to 50% there, and it's very similar in both treatment arms, so it doesn't change by chemo or no chemo backbone. On the other hand, the luminal subtypes have a lower PCR rate as expected. So this is basically the take from the PAM50 analysis.
Thank you.
I might ask one quick question, although it's not really a quick one. I agree with your last comment that the results support the development of this regimen in further trials, but I think a lot of us struggle with thinking about what those trials would look like. So what's your vision for taking this regimen further in early stage disease?
That's a great question. We actually don't know yet. The idea that this PCR rate of about 30% in patients receiving no chemotherapy in this group, we thought was supportive of further exploring the use of CDK4/6 inhibitors as companions for hormonal therapy in trying to de-escalate chemotherapy in this population. Exactly how, it's not really decided yet. But it's up for discussion, of course, and we look for opportunities for making new trials in this setting. Maybe new SERDs or new CDK4/6 inhibitors or new combinations can be used instead of the ones that we have used in our trial.
Thank you, Dr. Malorni. Very nice. Thank you. Our next speaker is Dr. Fleur Louis, who comes to us from Amsterdam, and her presentation is titled 3-Year Event-Free Survival of the Multi-Center Phase 2 TRAIN-3 Study Evaluating Image-Guided Optimization of Neoadjuvant Chemotherapy Duration in Stage 2 and 3 HER2-positive breast cancer. Welcome.
Thank you. Good afternoon, everybody. First of all, I would like to thank the organizing committee for selecting our abstract for this rapid-fire presentation. My name is Fleur Louis, and I'm a PhD student at the Netherlands Cancer Institute. On behalf of the Dutch Breast Cancer Research Group and my co-authors, I will present the primary endpoint of 3-year event-free survival of the TRAIN-3 study. I have no disclosures. Patients with stage 2 and 3 HER2-positive breast cancer typically have good outcomes with 6 cycles of anti-HER2-based neoadjuvant chemotherapy. 3-year event-free survival rates of 84 to 98% have been observed in prior studies. However, early complete responses after only 3 cycles are also common. Monitoring treatment response with MRI breast can help to predict the PCR and may identify early complete responders who could potentially forgo further chemotherapy. So the main question of the II and III study was, can we safely stop chemotherapy after 3 cycles in complete responders on MRI? We included patients with stage 2 and 3 HER2-positive breast cancer. They received neoadjuvant chemotherapy consisting of paclitaxel, trastuzumab, carboplatin, and pertuzumab. Response was monitored by breast MRI every 3 cycles, and patients underwent surgery once a complete radiological response was seen or after a maximum of 9 cycles. Local, regional, and adjuvant endocrine treatments followed the national guidelines. Patients with a PCR completed 1 year of trastuzumab and pertuzumab as adjuvant treatment. Those with residual invasive disease completed the 9 cycles of PHCP, followed by 14 cycles of TDM1. The primary endpoint was 3-year event-free survival, analyzed in intention to treat population. And secondary endpoints included adverse events, PCR, radiological response, quality of life, and 3, 5, and 10-year event-free and overall survival. The regimen would be considered successful if no more than 38 events occurred in patients with hormone receptor negative disease and no more than 34 events in HR-positive disease. We included 467 patients with a median age of 51 years. Most tumors were clinical stage T2 or T3. 60% were node positive at baseline, and the majority of tumors were HER2 3+ on immunohistochemistry. PCR results were already presented at this meeting in 2022 and published in the Lancet Oncology earlier this year. To summarize, 1 in 3 patients with HR-negative breast cancer and 1 in 6 with HR-positive breast cancer achieved the PCR after only 3 cycles of neoadjuvant chemotherapy. The accuracy of the MRI to predict the PCR was 87% in HR-negative patients and 53% in HR-positive patients. And now we move on to the results of the primary endpoint. After a median follow-up of 40 months, 3-year event-free survival was 92% in both groups. As you can see, 19 events occurred in HR-negative patients and 21 in HR-positive patients, both meeting the primary endpoint. 3-year overall survival was 97.8% in HR-negative patients and 98.7% in HR-positive patients. This slide shows the 3-year event-free survival stratified by the number of neoadjuvant chemotherapy cycles. What you can see is that patients who achieve an early complete radiological response have excellent outcomes after only 3 cycles of neoadjuvant chemotherapy. Event-free survival in these patients is 96 and 97%. Importantly, these estimates include patients who achieve an early complete radiological response but did have residual disease, demonstrating that early surgery does not negatively impact their survival. The incidence of grade 3 and grade 4 adverse events increased with the number of neoadjuvant chemotherapy cycles, as did grade 2 and higher neuropathy. We conclude that 1 in 3 patients with HR-negative, HER2-positive, and 1 in 6 with HR-positive, HER2-positive breast cancer achieve a PCR with only 3 cycles of neoadjuvant chemotherapy. These patients have excellent 3-year event-free and overall survival. PCR can be identified reliably with contrast-enhanced MRI for HR-negative tumors. However, better monitoring tools are needed for HR-positive tumors. And this therapeutic approach offers a significant reduction in toxicity for this patient population. Thank you for your attention.
Thank you, Dr. Louis. I open up for questions, starting with microphone 4.
Nick Murray, Adelaide. Fascinating presentation. Do you have any data on HER2 copy number or any other measure of ERB expression and likelihood of response early versus late?
Yes, we saw a higher PCR rate in patients with HER2 disease.
Sorry, I assumed they were all HER2 positive, but copy number?
Yeah, HER2 I said.
Right, I was thinking more of fish.
So you need some more information about the copy number. We didn't yet look into that, but that might be interesting to do. So we can do it later.
In Australia, we're only allowed to use Herceptin if the issue's positive, so copy number is something that comes up in our MDTs all the time.
Thank you.
One more question, microphone 6, please.
Sailija Kamaraju from Medical College of Wisconsin in Milwaukee. Great presentation. A quick question I have. MRI, you said that I think it's 80% accurate in your study. That's wonderful, but in clinical practice, we hear variations in reports and radiology reports and how patients feel the tumor size in terms of how you interpret that on MRI. My question is, did you do any functional MRI correlates or just tumor measurements on MRI to assess whether the pre-op chemo was working or not, effective or not?
Thank you for your question. We only followed the standard protocol for the MRI evaluation. And the main thing we looked at was whether patients had a radiological complete response. That was the most important thing for this study.
By
we will be
tumor
doing
measurements you're talking. So you measure the tumor size.
Yes, we will be doing some extra analysis on all the MRI scans we have from all patients in the study, but we're still working on that.
Thank you.
And one more question from microphone number 4.
Yeah. So I think of this question as under the banner of how short is too short in terms of long-term outcomes. What if someone has a PCR after one cycle of therapy? Is that enough? And, you know, I don't expect you to have an answer to that, but I just think it's something that we should all think about a little bit.
Thank you for your question. I think if a patient has a PCR after only one cycle, I think that's enough. I think we have, I think a few or part of the patient with HER2-positive disease respond very early and very well to the treatment. And I think in these patients, one cycle of neoadjuvant chemotherapy is enough if they achieve a PCR after one cycle.
Thank you very much, Dr. Louis. Please, come and join us. Okay, our next speaker is Dr. Azkar Ali from the Cleveland Clinic Foundation and Case Western Reserve University. The title of their presentation is Long-Term Follow-Up and Updated Analysis from S0221, comparing alternative dose schedules of adjuvant anthracyclines and taxane therapy in high-risk early breast cancer. Thank you.
Thank you, Dr. Goel. I would like to thank the organizers for selecting our abstract. On behalf of the investigators, I am delighted to present the long-term follow-up and updated analysis of S0221. These are my disclosures. Despite development of novel targeted agents, anthracycline and taxane chemotherapy remains the mainstay for high-risk early breast cancer. There is preclinical and clinical evidence that increased dose density of treatment by shortening the interval from every 3 weeks to 2 weeks or weekly results in improvement of disease-free survival. S0221 was a previously reported phase 3 randomized trial investigating the efficacy of weekly doxorubicin A with daily oral cyclophosphamide C versus AC given every 2 weeks, which was then followed by paclitaxel P, which was given either every 2 weeks or weekly. At the time of first interim analysis in 2010, weekly AC was unlikely to be superior to AC given every 2 weeks, and accrual was suspended. The trial then reopened with all patients assigned to 4 cycles of AC given every 2 weeks, and patients were only randomized by the paclitaxel factor. given either every 2 weeks or weekly. Here is the design. S0221 allowed patients that were male and female, 18 or older, SWOG performance status 0 to 2, pathologic stage 1 to 3 with the following listed high-risk criteria. 3,294 patients were enrolled, of which 2,716 patients were enrolled on the original protocol and randomized in a 2-by-2 design, 2 arms 1 through 4 with schedule as shown. An additional 578 patients were enrolled on the revised protocol and randomized to arms 5 and 6. Arm 5 included patients that received AC every 2 weeks for 4 cycles, followed by paclitaxel given every 2 weeks for 6, and Arm 6 included patients that received AC every 2 weeks for 4 cycles, followed by paclitaxel weekly for 12. Please note that Arms 5 and 6 received AC for 4 cycles, and Arms 1 and 3 received AC for 6 cycles. Primary outcome was disease-free survival, and secondary outcome was overall survival. Here are the patient demographics. On the left are shown the patient characteristics of patients on the original versus revised protocol. Patients on the revised protocol had a higher median age. More patients were node negative, and fewer patients had 4 or more positive lymph nodes. Fewer patients were hormone receptor positive, and more patients were HER2 positive or triple negative. And now the results. There were no statistically significant difference in disease-free survival or overall survival among the 4 arms on the original protocol. There was also no statistically significant difference in disease-free survival or overall survival among the 2 arms on the revised protocol. Subgroup analyses were conducted using the patient data from original and revised protocol to generate the following results. When patients were stratified by disease subtype, HER2-positive patients had the best disease-free survival or overall survival. When patients were stratified by sex, men had worse disease-free survival or overall survival, though the numbers were small. And when patients were stratified by race, Black patients had worse disease-free survival and overall survival. Once again, those numbers were also small. Now the toxicity results. There was more myelosuppression in arms that received AC every 2 weeks for 6 cycles and AC weekly for 15 weeks, compared to arms that received AC every 2 weeks for 4 cycles. There was a similar incidence of cardiac toxicity among the 6 treatment arms. There was more hand and foot syndrome in weekly AC arms. And there was more neuropathy with paclitaxel given every 2 weeks for 6 cycles. The final analysis of S0221 showed no difference in efficacy in any of the 4 treatment arms of anthracycline and or taxane schedule, or in the 2 arms of the revised protocol. HER2-positive tumors had the best disease-free survival and overall survival. Although the benefit of HER2-directed therapy, trastuzumab versus chemotherapy, is hard to distinguish. Adjuvant trastuzumab was FDA approved in 2006, and patients were allowed to receive trastuzumab. Weekly anthracycline for 15 weeks did not improve efficacy. Selection and schedule of regimens should depend on patient preference and toxicity potential. We would like to thank the patients and their families for their involvement in the S0221 study. We would like to thank the study sites, investigators, and research staff. I would like to thank Dr. Tom Budd and Bill Barlow for their review of the slides. Thank you.
Thank you, Dr. Ali. Open up for questions. I might start if that's okay. One thing that I think many of us would have found interesting is that you clearly observed, again, clear racial disparities in outcome in your trial. And I think a topic that a lot of us are thinking about is to what extent that's driven by social determinants of health, to what extent biology might play a part. Do you have, I know it's a long time ago, but do you have the tissue from this trial, the surgical tissue, and is there any way you can use it to interrogate that question?
So that's a great question. That's come up obviously a lot in our, working through the data now as we're working on the manuscript. It is unlikely that we'll be able to go back and do that level of biomarker level work. The socioeconomic determinants, I think that's a great point. I don't believe we have that level of data, but we are planning to do some additional multivariate analyses to see what we can sort out in terms of patient individual risks and then stratify in terms of race and sex.
Thank you. All right, we have no more questions. We might move on. Thank you very much. Our next presenter is Dr. Saya Dennis from Northwestern University in Chicago, and her presentation is entitled DNA Methylation Patterns Are Similar in Benign Tissue from Ipsilateral and Contralateral Breast, while different from matched breast cancer and healthy controls.
Thank you. Happy to be here. All right, so let's start by briefly going over our study motivation. In breast cancer genomic characterization, tumor-adjacent normal tissue is often used as a reference for tumor. However, some studies have found that tumor-adjacent normal tissue shares some genomic characteristics with tumor, and trends in the contralateral breast in particular remains elusive. Our study explores this area with the following study design. We have 72 cancer cases from Northwestern University and 182 cancer-free controls, or folks who are unaffected by cancer, from the Komen Tissue Bank. We have 4 categories of tissue from cancer cases, namely tumor, tumor-adjacent normal tissue, opposite quadrant of the affected breast, and contralateral unaffected breast, as well as 1 tissue category from cancer-free normal breast. These 5 tissue categories form a clear order in their proximity to tumor and can be placed along what I defined as the tumor proximity axis. In our study, we are focusing on DNA methylation assayed using Illumina's Infinium EPIC V1b chip, since DNA methylation offers us a robust and long-term indication of gene regulation compared to something like RNA-seq. PCA of the methylation profile showed separation of tumor samples, as well as the samples that came from cancer-free normals. And the remaining 3 categories, which are the case-benign tissues, were bunched up in the middle together. For differential methylation analysis, we focused on these 4 pairwise comparisons between neighboring categories along the tumor proximity axis. And here I'm summarizing the number of differentially methylated CpGs in a Sankey diagram. So in short, the height of the bar at each comparison represent the number of CpGs that are hypomethylated, hypermethylated, or not different. So let me walk you through our findings. First, the left end of the Sankey diagram, as well as the PCA plot, tells us that the tumor samples are highly distinct from the rest, characterized by numerous hyper and hypomethylation events. Next, the right end of the Sankey diagram, as well as the PCA plot, again, tells us that cancer-free normals are also distinct from all the other case-benign tissues, but this time mostly dominated by hypomethylation events. Finally, we can also see that the 3 case-benign categories that we have here are largely similar to each other in their methylation profiles. Transcription factor binding site enrichment analysis showed us that the hypermethylation events distinguishing tumor from adjacent normal were enriched for the binding sites of the polycomb repressive complex, a known key player in breast cancer. Interestingly, the hypomethylation events distinguishing tumor from adjacent normal, as well as those distinguishing contralateral breast from cancer-free normal, were both enriched for the binding sites of factors well described in breast cancer. I do want to note here that even though the enrichment hits are overlapping, the specific binding sites might differ. For example, they might map to different genes, or for a given gene, it might map to different areas of the gene. And there were also transcription factor hits that were unique to one comparison and not to the other, such as FOXA1 and HOXP13 highlighted in the left here. Next, we looked at how the methylation profiles differed by the paired tumor's ER status. Again, we started by looking at sample clustering. The top panel here shows samples that came from ER positive, samples that are paired to ER positive tumor, and the bottom to ER negative. The first thing that we can see here is that the tumor samples seem to be highly distinct in their methylation profiles based on ER status, but no such distinction is seen for the case-benign tissue categories. Differential methylation analysis showed that the events that distinguished ER-positive tumor from ER-negative tumor were expectedly enriched for the binding sites of hormone receptor-related transcription factors. The same was seen for the comparison between ER-positive tumor and their paired case-benign tissue categories, but not in the ER-negative comparison. Interestingly, we saw no differential methylation between case-benign tissues that are paired with ER-positive tumor and ER-negative tumor, indicating that case-benign tissues do not seem to show indication of their corresponding ER subtypes. We also saw that the comparisons between case-benign tissues and cancer-free normals were both enriched for hormone receptor-related TFBS, telling us that trends related to ER signaling are seen in all case benign categories, regardless of the paired tumor ER status. So let's summarize our findings. First of all, we saw that selecting a case benign tissue categories as your reference to tumor may not capture the entire tumor normal differences of methylation profiles and should be interpreted with caution. We also saw that the 3 case benign tissue categories in our study were largely similar to each other in their methylation profiles, and differences between case benign tissues and cancer-free normals were related to HR signaling. We saw that for the tumor samples, the methylation profiles differed globally by ER status, but case benign tissues did not seem to show indication of their corresponding ER subtypes. Last but not least, regardless of the tumor ER status, the case benign tissues showed patterns related to hormone receptor signaling. Finally, I would like to acknowledge the support and guidance of everyone who contributed to this project. Thank you for your attention.
Thank you, Dr. Dennis, for that very interesting presentation. Questions starting with microphone 4.
Nick Murray, Adelaide. That is absolutely fascinating. If it's across both breasts, then the founder event has to have occurred either very early in embryogenesis or actually be an epigenetic germline thing that's been transmitted from the parent. Do you have any speculations about which of those it might be? And have you considered looking at other tissues from those individuals to see what their hypermethylation status is?
Yeah, great question. So this is definitely what we're exploring right now. And this will be speculation, but what we're hypothesizing is that it's sort of an estrogen exposure that is causing sort of a whole body response. And that's why we're seeing a lot of hormone receptor related epigenetic patterns in all of the case benign categories, not just the adjacent normal tissue to tumor. So that's sort of what we're exploring right now. If we can have other, for example, blood from these cancer patients and look at whether we can find estrogen exposure signature in their blood, I think that would be really, really interesting. We do not have that at this point, but that's a great question. Thank you.
Thank you. Yeah, I think that's fascinating data, and it's a really good example of how normal tissue banks can be used to uncover aspects of breast cancer biology. Unfortunately, we don't have time for more questions, but thank you again. Our next speaker is Dr. Katie Johansen Taber from Myriad Genetics. And her title of her talk is Association of Polygenic-Based Breast Cancer Risk Prediction with Patient Management.
Well, thank you, and thank you for the invitation to speak about the Association of Polygenic-Based Breast Cancer Risk Prediction with Patient Management. I'd like to thank my collaborators from Myriad Genetics, Optum, and Stanford University. Let's see here, there we go. My disclosures are that I'm an employee of and a stockholder in Myriad Genetics. So the Tyrer-Cuzick breast cancer risk predictor is a validated breast cancer risk prediction tool. And we have shown previously that a risk score that combines the clinical factors from the Tyrer-Cuzick risk calculator with breast cancer risk SNPs, which we call the combined risk score, or CRS, is a more accurate predictor of breast cancer than Tyrer-Cuzick alone. And guidelines recommend that those with a predicted lifetime breast cancer risk of above 20% should undergo enhanced management, including annual screening mammography as early as age 30, annual breast MRI, and referral for genetic counseling. So our question was, because these polygenic-based breast cancer predictors are relatively new, we wondered whether clinicians were using them to inform that patient management that I just spoke about on the previous slide for those who have a high risk of breast cancer. And so to answer these questions, we linked Tyrer-Cuzick and combined risk score results to claims data using a tokenization process. And that created a de-identified data set with results, Tyrer-Cuzick and CRS results, and longitudinal health outcomes. And then we took that de-identified data set and we created a study cohort from it. We included patients that were age 18 or older and had continuous medical and pharmacy insurance enrollment for the year before and year prior to receiving the CRS result. And we excluded patients if they had a history of breast malignancy, any metastatic cancer during the baseline period, evidence of any breast cancer prevention measures prior to receiving the CRS results, and evidence of any breast cancer diagnosis after receiving the CRS results. And so then we took that cohort and we divided it into 4 subgroups based on the predicted lifetime risk of breast cancer by either the CRS or Tyrer-Cuzick. So we ended up with 4 subgroups, one for which the CRS and Tyrer-Cuzick both predicted a high risk, which is a risk above 20%, lifetime risk above 20%. One for which the CRS and Tyrer-Cuzick both predicted an average lifetime risk, which is below 20%. And 2 groups for which the CRS or Tyrer-Cuzick predicted high risk, but the other predicted average risk. And this is how the cohort broke out. So we had a total of about 8,600 patients, and a little more than half of them had an average risk of breast cancer predicted by both the CRS and Tyrer-Cuzick. A little more than a quarter of them had a high risk of breast cancer predicted by both the CRS and Tyrer-Cuzick. And the remaining about 18% had a high risk of breast cancer predicted by either the CRS or Tyrer-Cuzick, but not by both. And when we look a little bit closer at those discordant results, what we see is that in patients for whom Tyrer-Cuzick predicted a high risk of breast cancer, the CRS actually predicts an average risk of breast cancer in about 26% of those. And for patients in whom the Tyrer-Cuzick predictor predicted average risk, the CRS predicted high risk in about 13% of those patients. And when we look at those screening interventions that I mentioned on the first slide, what we see is that in patients for whom the CRS or Tyrer-Cuzick or both predicted a high risk of breast cancer, those screening interventions, the frequency of those screening interventions was increased. So the frequency of screening mammography was increased by about 2 to 2.5 times. The frequency of breast MRI was increased by about 18 to 14 times. And the frequency of referral for genetic counseling was increased by about 2.5 to 3 times. And that's relative to those for whom the CRS and Tyrer-Cuzick both predicted average risk. So our conclusion is that the CRS predicted a different risk level than Tyrer-Cuzick for a substantial proportion of patients. Those with a high risk predicted by both the CRS and Tyrer-Cuzick, or one or the other, received screening consistent with guidelines. And those who received a high-risk CRS result, those results may have influenced clinicians to recommend enhanced management. Thank you.
Open up for questions. I might get started. So the polygenic assay that you're describing, I think for many of us who maybe don't work in the US, we may not be so familiar with that.
Sure, yes.
So I'm wondering if you could just briefly describe it and also discuss its applicability for people from different ancestries.
Yes, right. So the CRS that is offered by Myriad Genetics is validated across all ancestries. The current version of it screens for about 100 breast cancer SNPs and about 50 ancestry-related SNPs, and is combined with the clinical factors from the Tyrer-Cuzick risk calculator. But because of those ancestry-related SNPs, we are able to modify and predict risk accurately across all ancestries. And I'll just note that we have a poster spotlight actually being presented tomorrow that is talking about an updated version of that risk score that we are working on.
Thank you. We have a question at microphone 6.
Ahmed Al-Kanani, Baylor College of Medicine. That's fantastic work. I assume, are you going to eventually correlate that with outcome, including patients, primary cancers?
Yes. Yes, we would like to. You can imagine that that's a difficult study to do because it requires a very long follow-up time. We might be waiting decades for a person with a high risk of breast cancer to actually develop breast cancer. So we need to come up with some some creative ways to measure that and power that study. One of those ways is to use claims data like this, where we have a huge sample cohort to catch those people who, the small proportion of patients who might develop breast cancer in a shorter amount of time.
Yeah, thank you. I have a very small follow-up question.
Yeah.
Do you have as far as I know, in the NCCN guidelines, having a polygenic risk score that is elevated does not inherently lead to recommendation of extra MRI screening. So why are the patients who are TC negative, Tyler Cusick low score, but positive CRS ended up having more MRIs?
It's a great question, and I think we did this study to understand whether clinicians who are receiving those high-risk results would take them seriously and manage patients according to them, despite the fact that guidelines do not yet say that PRSs should be supported. It's a great question. I think sometimes guidelines happen because there is a demand by clinicians to actually use those kinds of tools.
And outcome. Perfect. Thank you.
Thank you.
Thank you very much, Dr. Taber. Okay, our final presentation for this session is given by Dr. Polly Neeravath, and her talk is entitled A Multi-Factor Analysis for Pathologic Complete Response in a Chemotherapy-Free Regimen of Durvalumab, Trastuzumab, and Pertuzumab, the DTP Trial, in HER2-enriched early breast cancer.
Thank you. On behalf of myself and my co-investigators, I want to thank the organizers for giving us the chance to share this data that we have that we're very excited to tell you about today, which is a follow-up on our previous trial called the Durvalumab, Trastuzumab, and Pertuzumab trial. These are my disclosures. So it's no secret that not all HER2-positive breast cancer is created equal. So in this trial, we attempted to identify that group of patients who are exquisitely responsive to anti-HER2-directed therapy and treat them with only the combination of durvalumab, trastuzumab, and pertuzumab for 6 cycles. So all of these patients had to have stage 1 to 3 HER2-positive breast cancer, and they also had an Agendia genomic assay that identified them as being HER2-enriched. These patients then went on to receive this targeted therapy that we call DTP. And those patients who responded went on to get surgery. And those patients who were either clinically or radiographically not responding went on to get physician's choice of neoadjuvant chemotherapy, which was typically docetaxel, carboplatin, trastuzumab, and pertuzumab as per standard of care. After surgery, those patients who achieved either an RCB0 or RCB1 continued DTP therapy only, and everybody else completed standard of care adjuvant therapy as per the Catherine trial. The primary endpoint for the trial was pathologic response rate, defined as a PCR, as an RCB of 0 or 1, and that data was previously presented at AACR. Just as a recap, that data was quite exciting in that we found that roughly 2/3 of patients were able to achieve a pathologic response, and almost half of patients achieved a pathologic complete response. And if we go back and we include the patients who are non-responders, which was a total of 6 patients of the 37, we see that the numbers of pathologic complete response are about 56.8%. So we wanted to dive into this data a little bit further and see if we could understand or predict who may be a responder to this targeted therapy. As you can see here, clinical stage and tumor size do matter. T1 and stage 1 tumors had a higher rate of pathologic complete response as compared to larger tumors and later stage tumors. Similarly, patients who had TILs greater than 10% were also far more likely to exhibit a pathologic complete response. And patients who had a CPS PD-L1 score greater than 10% also were more likely to have a pathologic complete response. And we also used the HER2-DX assay with the help of Dr. Pratt and his lab. And as you can see here, particularly when we look specifically at the subset of those that had favorable luminal differentiation signatures as well as proliferation signatures, those patients were more likely to achieve a pathologic complete response by our correlation analysis. And then for the summative model PCR score overall, this was also predictive of achieving a pathologic complete response. We then went on to analyze this data further using single-cell sequencing. And this was an exciting task because using these 37 patients, we had paired baseline and end of treatment samples, which allowed us to look at nearly 500,000 total cells. In this, you can see here that the overall data tells us that it seems that responders at baseline, shown here on the left, as compared to non-responders at baseline versus end of treatment, clearly have different cell makeups. Specifically, when we look at the individual types of cells, what we can see is that it tells a nice story here, that as we would expect, patients who are responders at baseline have higher concentrations of plasma cells and B cells. And we also see that patients who are non-responders have higher concentrations of myeloid cells, both at baseline and end of treatment. So it's clear that those patients who seem to have more immune potential respond better to this treatment. We also wanted to understand better what those myeloid cells were indicating. So looking specifically at the subset of the myeloid cells, we can see here that the non-responders had significantly higher rates of SPP1 positive tumor-associated macrophages as compared to the responders. And we know that these specific SPP1 positive macrophages have been associated with chemotherapy resistance and worse clinical outcomes in multiple other publications previously. So this data together helps us understand that perhaps in the next iteration of this treatment, we may be able to select patients more accurately for who may respond with pathologic complete response. In this HER2-enriched subset, the de-escalated durvalumab, trastuzumab, and pertuzumab regimen was well tolerated and achieved high response rates. Several clinical and pathologic parameters correlated with pathologic complete response, specifically smaller tumor size, earlier cancer stage, higher percentage of TILs, and higher PD-L1 CPS score. In the molecular analysis, the factors that correlated with pathologic complete response were specifically the luminal differentiation signature and proliferation signature on the HER2-DX assay, as well as the summative model PCR score. And we also saw that larger populations of B cells and plasma cells predicted for higher likelihood of response, and conversely, higher SPP1 tumor-associated macrophages were associated with non-responding status. Thank you. Oh, and thank you also to all of the clinical and pathological collaborators that we had for this project. This very brief presentation actually took a large village of people to complete. So thank you to everyone who made this work possible.
We have time for some questions, starting with microphone 4.
Yes, thank you. Bill Sykov from Brown University. An excellent presentation, very intriguing data. I'm curious, did you look as to whether the molecular markers would overcome the lower path-CR rate seen in patients with larger tumors?
So this is an interesting question, but no, our sample size is relatively small. So it's difficult to get into that degree of analysis, with such small numbers. But no, we haven't looked specifically at that question.
Thank you. I might ask one question. Some of us might have been a bit intrigued or surprised at this tendency that tumors with a more luminal differentiation signature did better. I'm wondering if that was something you would have expected or how you interpret that result.
Yeah, so that data, we had the same question. And the way that that data works is that in that particular graph that I showed you, the luminal signature is somewhat negated, meaning that if someone does not have a luminal signature, it's more likely they'll get a path CR. So in order to calculate that model PCR score, that luminal differentiation signature is essentially reversed. So what you're seeing on that is that the people who did not have a luminal signature actually had a higher chance of path CR.
I see. Okay. Thanks for clarifying that. Mm-hmm. All right. Well, look, I think it just gives me one last minute to say thank you, all of you, for coming to this session. Thank you very much to all of our speakers. They're all doing tremendous work, all gave fantastic presentations. I'll draw the session to a close and hope you all enjoy the rest of the conference. Thank you.